But to start, one of the final poems to share with you, forgiveness. Through God's love, you always have infinite forgiveness. Unfortunately, you don't always have infinite time. This is actually through a homily I heard at church. Somebody had asked a priest, John Wayne was he didn't believe in Christ at all. And then when he was dying of lung cancer, it's amazing, people find Christ just before they die a lot of times, okay? Because now you want to hope there's something else after you die. Well, he found Christ, and he asked Christ to forgive him for not believing all that time. And so somebody asked the priest, does that mean God will forgive him, and even though he hated God all this time? And the priest said, yes, God doesn't hold anything against you. Once you sincerely ask for forgiveness, you're forgiven as of that very moment. And I truly believe that. That's why, I believe it's better to put somebody in jail for life rather than kill them. Because as long as they're in jail for life, they have a chance to redeem their soul. Versus if you kill them today, there's no chance to redeem their soul. All right, we move on. Physiology of Cancers, man, this is about cells out of control, Jenny. Just like girls gone wild, these are cells gone wild, Jenny. That's right, we got videotape of them, too, going wild. At local bars, available right now, $9.95. If you call now in the next 8 minutes, I will send you the other tape about cells gone wild. Yeah, it's amazing. All right, so let's say Jenny's just going about her business, living life, having a good time. We're going to compare Jenny to a cell, okay, and see what happens. So normal growth is what's happening. Jenny going about her business, and all of a sudden, here comes a stressor. Here comes a man. So stress, poor Jenny. Well, she has 3 choices, just like a cell has 3 choices. Number 1, atrophy. That means to shrink away, decrease in cell size. All right, so these are the first levels of response, that they're still mature. Atrophy, decrease in cell size. Hypertrophy, increase in cell size. Or hyperplasia, increase in cell number. So if we match it with what Jenny's going to do, she can either shrink away, that means hide at home, because that man's got her so depressed. Oh, he broke her heart. Or she can stand up tall and strong against this man. Tell him, get out of my life. And then come back next week. So. Or hyperplasia, increase the cell number. She can get some help. Call a local psychiatrist, helpline, something. This man is stressing me out. Well, again, first line of response, mature. What if the stress goes away? Then you stay there. But if the stress continues, second line response are these 3 words: anaplasia, metaplasia, or desmoplasia. Let's see what they mean. Anaplasia means the cells revert back to their mesenchymal origin, which means for Jenny that would be called regression. That means she goes home, curls up on the couch in the fetal position, starts sucking her thumb and calling mama on the cell phone with the other ear. So that's true regression, all right? Anaplastic cells means that they stay in that phase. That means the original cell of origin. But that means they need no time for maturation anymore. Uh-oh, wait a minute. That means every time they divide again, they divide again, they divide again, because they don't need any time to mature. Everybody understand this? This is the most malignant type of response. Anaplastic cancers are the most malignant type of cancers, the most aggressive, the most metastatic. They have the highest mortality. But because, Ferdy, they are rapidly dividing, how do you know to stop rapidly dividing cells, Ferdy? Yeah. How do you stop rapidly dividing cells? I heard you're the master of stopping rapidly dividing cells. What kind of medications have we talked about, Ferdy, that can stop rapidly dividing cells? Yeah, just look at the screen anytime you forget. Anytime it's just to keep the flow, folks, but in case you forget, just look at the screen. All right, remember chemo and radiation. Let me give you an example. Small cell carcinoma of the lung is anaplastic. Oat cell carcinoma is anaplastic. Guess which lung cancer is the most aggressive? Guess which lung cancer is the most metastatic? Guess which lung cancer has the worst prognosis? Guess which lung cancer, however, can be treated with radiation and chemo? The other ones can't, but this one can. Big picture first, folks. That's what I'm telling you. You got to know big picture, because that means if they pull out another one, so what? I'm going to tell you the same stuff again. And yet I've never read about it, don't need to, don't want to. Because here's the concept that answers the question anyway for me. All right, so anaplastic. So that means if we liken it back to Jenny, it's like Jenny get man enough and open up a big old can of whoop ass. You know, got that martial arts stuff going on, boy, and that man lived to regret it. And then the next episode, his brother showed up. You killed my brother. I want satisfaction. All right, so that's anaplasia. Metaplasia is replacement of one adult cell type for another. One adult cell type for another is what metaplasia is. Well, it has to be an adult cell type that can handle the stress there, P-nish. What do I mean by that? Well, squamous cells can handle a lot of abrasive irritation. The other cells can't. So let's say, like in the female cervix, STDs of the cervix, that's a lot of irritation. That's why the cervix goes from columnar to squamous. You always got to figure out the change by what the irritant is. For like Barrett's esophagus, remember from the stomach, the esophagus squamous cells become columnar. Why? Columnar cells can handle acid. Squamous cells cannot. Okay? So instead of always thinking back to what you read out of Robbins, just think about what the irritant is, and you can tell me what kind of cell it has to metaplase into. Does everybody understand that? All right, so metaplasia, one adult cell type for another. Okay? Desmoplasia means a collagenous reaction surrounding the tumor. We talked about this in collagen. Okay, so metaplasia for Jenny would mean she goes to an assertive training class and learns how to be somebody different. Be more assertive. Tell him what your feelings are, Jenny. Tell him you don't like what he's doing. Tell him to hit the road and never come back. Okay? For desmoplasia, collagenous reaction, that's Jenny wrapping her heart with collagen. Says, no man will ever hurt me again. Ah, no man will ever break my heart. Ah, now she's got an ice box where her heart used to be. Too much music in the morning. All right, so desmoplasia. All right, so again, with desmoplasia, they'll say, oh, well, you can see collagen reaction around that tumor. Now, remember, that's any tumor or cancer. It's nonspecific. All right, but if the stressor continues, Jenny, then we get Jenny to say, you know what, I'm quite displeased with this. For the cells, they say the same thing, I'm displeased. And that's why they undergo dysplasia. It's when a cell is displeased. Well, what do you see in dysplasia, Jenny? Dysplasia is when cell-to-cell contact inhibition has been lost. Jenny, that is not a good thing. When cells come in contact with each other, all right, hold it. You stay over there, I stay over here. When cells come in contact with each other, up, there's boundaries. Stay over here, I stay over here. When cells do no longer obey that rule, when they come in contact with each other, oh, they start crawling on top of each other. Now, Jenny knows it's not good when cells start crawling on top of each other, Jenny. When they start crawling on top of each other, they start breaking the rules. And if you start breaking the rules, all of a sudden they start multiplying. You know what happens, Jenny? Keep me crawling on top of each other like that. They start multiplying, and before you know it, you got cancer. You got cancer, or you got a baby, one or two. So anyway, so display. They're both rapidly dividing cells now. You got to think about it. So dysplasia means that you've lost cell-to-cell contact inhibition. Now, it turns out, Tony, dysplasia is the same thing as carcinoma in situ. Now, for the boys 2 and 3 people, CIN, they talk about 1, 2, 3. That just means the upper 1/3, middle 1/3, lower 1/3. Okay, so 1, 2, 3. All right, because remember, cancer grows down to break the base membrane. Everybody follow? All right, so dysplasia is the first stage of cancer. You understand, Fazil? Well, when we screen for cancer, Fazil, we're always trying to catch cancer in the earliest stage, are we not? So that means when we're screening for cancer, Fazil, what stage are we looking for? Stage 1. What are we looking for underneath the microscope to know it's stage 1, Fazil? Evidence of what? Evidence of what? signs of dysplasia, which means, Andre, what are we looking for underneath the microscope? Loss of inhibition of cell-to-cell contact. That means they're crawling on top of each other. That means, Nicole, anytime we screen for cancer, what are you looking for? That means when you biopsy a polyp, what are you looking for? You do a pap smear, what are you looking for? Breast biopsy, what are you looking for? Does everybody understand what we're screening for? That means when they ask you about screening for another cancer, don't start telling me about something different. That means you missed the big picture again. That's how they get you. You swear the answer is different, guess what? You'll miss out on the point again. Folks, we're always trying to catch cancer in the first stage. Well, what is the first stage? That's how you know. If you catch cancer in the second, third, forget it. It's too late. Why are we going to be screening for that? The reason we do first stage is because if you can catch cancer in the first stage, you got a 90% 5-year survival if we take it out. If we remove it, 90% chance of still being alive in 5 years. All right. Now, if the stress continues, look at the graph. You now undergo neoplasia. You know what neoplasia is, Linda? The word says neoplasia, which just means new growth. You see that, Linda? You see that, Andre? Neoplasia does not necessarily mean cancer, does it? Does it, Linda? Does it, Andre? All right, folks. On the boards, they typically use 3 words quite a bit. Tumor, mass, neoplasia. Why? You have no idea what these 3 words mean yet. Students always throw straight to cancer. That's not what these 3 words mean. But students always run right to cancer. That's why it's a setup. If you look at masses overall, here's what we find. You're going to get about 10 benign masses before you get 1 malignant one. So why do students run straight to the malignant one? It's because that's what you've been reading out of your books. That's what I mean by your book set you up. You keep thinking because the author keeps talking about the malignant one, that must be the most common. But that's not it. Physiology tells you benign is 10 times more common than malignant. Everybody follow me? So here's how you apply it in medicine. Whenever a woman has an ovarian mass or a breast mass, we take out all of them because we don't know really what it is yet. All right, so that means if they remove a breast or ovarian mass, tumor, neoplasia, I'm going to assume it's benign because that's what the odds are. Everybody follow me? Before I ever assume it's malignant. Does everybody understand me? This is when they don't say benign or malignant. If they say benign, great. If they say malignant, everything I just said is a non-issue. This is because 90% of the time they use these 3 words. Students just jump and pick the wrong answer. All right, so breast and ovary, because we remove everything and then let pathologists tell you what it is. So by chance alone, benign first, malignant second. Everybody understand? However, every other part of your body, any mass, tumor, or neoplasia that they removed, key word, removed. For every other part of your body, folks, we biopsy everything and only remove the malignant ones. You're being tested as a physician. You got to think like one. That means if they remove a mass, tumor, or neoplasia from any other part of your body besides breast and ovary, I got to assume it was malignant for them to have removed it. Because that's the way we roll, Mustafa. So that means, Mustafa, if you remove somebody's testicle, a testicular mass, was that mass malignant or benign, Mustafa? You got to assume it was malignant. Because that's the only thing that'll make that man happy when he wakes up and he find out you took out his testicle. Is it better be malignant? Does everybody understand? Okay. It's over 90% accurate. That's why I'm just sharing it with you. Because they love to use those 3 words, and students just guess the wrong one. So breast and ovary, assume it's benign. If I don't see an answer that goes with benign, then I assume it's malignant. Then you'll see your answer. For any other part of the body, any mass or tumor they removed, assume it's malignant before you start thinking benign. But if they say benign, no problem. If they say malignant, no problem. What if they just give you a hint at it? Then you better know the words that go with either one, Josh. For benign, they'll say well circumscribed, freely mobile, well encapsulated. That means it didn't outgrow its capsule, Thomas. Does not outgrow its capsule means it does not have to go somewhere to find more blood supply because it didn't outgrow its blood supply, which means it does not metastasize. So these are all buzzwords that go with benign masses. And look at that. It obeys physio. Like when a woman comes in with a breast mass, why do you think we ask her, does that mass change with your periods? That means it still obeys physio. That makes me happy. I said, good. That's a benign mass. All I got to do is figure out which benign mass it is. Think about a female with a uterine fibroid. Why do you think that thing goes up and down each month with her periods? Because it's estrogen dependent. That's why. So anything that obeys physio, you say, good. That's benign. Does everybody understand me? All right. Because like one common question, they'll put, you know, they know you've been reading out your books, upper outer quadrant is the most common location for breast cancer. So they'll put a mass up there, but they'll say, well circumscribed, freely mobile, and students still go clicking cancer anyway without even reading the information. That's what I'm saying, folks. If you stop reading the clues in front of you, you'll be spitting out what the book told you, but that's not the answer. They give you information for something else, and you still believe what the book said. Okay? So those are the words that go with benign. Now, number one reason for surgery on benign masses, cosmetic reasons. Number one reason for surgery on benign masses, cosmetic. You know? I told you with the little girls, moms and dads don't want any masses on their little girls. They'll pay because the insurance will not pay for that. That's cosmetic surgery. You pay that yourself. All right, but the parents are happy to pay to have a little girl get a mass taken off. I told you the little boys, they just leave that stuff right there. Little boys got tumors going out that way, going out that way. So they got a hat facing this way, a hat facing that way. Nobody can see it. Don't worry, son. No problem. Anyway, malignant ones. Oh, wait a minute. What's the number one medical reason for surgery on a benign mass? The first one I gave you, cosmetic, is just overall. But when do we, as physicians, take out benign masses? Compression. That means if it's compressing something, you need to get out of there. Look at that uterine fibroids. Women live with fibroids all the time. She just has a little heavy bleeding during periods. We don't take out fibroids automatically. But look what happens when she comes in complaining about pelvic pain and pressure. See that? That means it's big enough to compress something, get it out. So again, big picture, folks, big picture. So the question I see on the exam, I remember the last one I saw, what's the number one reason for surgical removal of a lipoma on the back? Lipoma is benign. All I say to myself is I need an answer that means something's being compressed. I look down. Oh, right leg weakness, sciatic nerve. I say, that's the one right there. Everybody see my point? All right, concept never changes. They could have picked any nerve they want. As long as it come out the back, because that's where the tumor is, I got to pick it. Okay? All right, over to malignant ones. How do I know it's malignant? Oh, the lead. Because they say it's not circumscribed anymore. It's adherent. That means it's grabbing on the tissue. That means it's not encapsulated. That means it's outgrowing its blood supply. And if it outgrows its blood supply, it has to metastasize somewhere to go get it. And malignant masses do not obey physio. That's why, like in a female, any bleeding between periods, folks, after age 35, you got to do an endometrial biopsy. That's cancer to rule otherwise. Because there's nothing physiological that can explain why is she bleeding between periods. You can't say, oh, well, just a little bit of bleeding. It's no big deal. Okay, watch if you get a point on the exam. You won't. Okay? Any bleeding between periods in any female after age 35 must biopsy for cancer. Okay? Number one reason for surgery on malignant masses, invasion. They all invade something eventually, which means they're going to stop something from functioning. So number one reason for surgery on benign masses, remember with cosmetics. For medical reasons, compression. Number one reason for surgery on malignant masses is always invasion of something. Anytime you have a malignant cancer, Frank, the cancer produces two hormones that we need to know. Number one is angiogenin, Frank. Look at the word, angio, blood vessels, genin, genesis. Angiogenesis. Cancers produce their own blood vessels. Why? They're trying to suck the blood away from you. Remember, malignant cancers are rapidly dividing, so they need a lot of blood supply for the ATP needs. Angiogenin. Well, let's say, Kathy, that you're a malignant mass, okay? You're going to produce a lot of angiogenin. So that means anytime they describe vascularity, hemorrhage, and necrosis, you see, that's how I know it's got to be malignant. Everybody follow me? Everybody understand that? All right. So let's say Kathy is the malignant mass. And let's say Nicole is the one cell, her little daughter that wants to go away and find her own fortune in the world. And Kathy, the mama said, little chiquita, you must stay here. And the girl says, no, I want to find my own fortune in the world, mama. And Kathy says, no, you should stay here with mommy. And she said, no, I want to find my own fortune. So Nicole goes away. So what does mommy do? Whip out some endostatin. The main cancer always produces a lot of endostatin too. Why? For any cell that got away to make sure that cell cannot take over the blood supply. You see how selfish a cancer is? The cancer will make sure that it gets the blood supply, but any cell that peels off and goes away cannot suck blood supply away from it. That one cell that got away will just go somewhere and lay dormant for a while because she can't get enough blood supply to grow. Okay? It also stops other cancers, even if it's not related to the original cancer. It stops other cancers from growing. Now, you know, once we figured this out, we thought, hey, what about if we give somebody angiogenin when they had a stroke? Everybody follow? Well, it worked. They grew new blood vessels. The only problem is new blood vessels are very leaky. And if you leak blood into your brain, you just turn an ischemic stroke, which is good prognosis, into a hemorrhagic stroke, which is poor prognosis. So we stopped that mess. Okay? They've also experimented with endostatin. How about if we inject some endostatin and stop the cancer from growing? Well, it worked. The only problem is it stops every other organ from growing too. Not good. So we stopped that mess. We don't do that anymore. All right? So angiogenin and endostatin. Well, if you use chemo or radiation, Kathy, to zap a cancer, the definition of good response is when 1 billion cells have been wiped out. The definition of good response to radiation or chemo says 1 billion cells have to be killed. Well, Lauder lead, it turns out that whenever you have 1 billion cells, you can now see it or you can touch it with your finger. Do you understand? Until you have 1 billion cells, you cannot see it and you cannot touch it. Do you understand, Lauder lead? Do you understand that, Kimberly? So that means after we treat someone with chemo or radiation, can we say the cancer is completely gone, Kimberly? No. All you can say is we can't see it and we can't feel it. That's why we say you are in remission. Because there could be 1 million cells, but we can't feel it yet at 1 million. There could be 10 million, but we still can't feel it. Everybody follow? That's why we say you're in remission. And then, when you give somebody radiation or chemo, Thomas, remember, radiation or chemo is targeting rapidly binding cells, right? But Thomas knows he also has rapidly binding cells, don't you, Thomas? Name 3 of them. Yep. Skin. Hair. Nails. All right, well, remember cuticles now, not the nails itself. But remember we went through the side effects of all chemo. It's based on rapidly binding cells. So dry skin, hair loss, bone marrow suppression, nausea, vomiting, diarrhea. Everybody follow that, right? All right, the problem is you got to ask yourself, when you're wiping out the cancer cells, you're also going to wipe out my rapidly binding cells. Everybody understand that part, right? That means there's a chance you wipe me out. And we said that. There's no such thing as safe chemo. The question is, when you zap the cancer cells, how long does it take for them to get back versus how long does it take me to get my rapidly binding cells to come back? Well, Linda knows if I wipe out all your rapidly binding cells, you know about how long it takes for all your rapidly binding cells to come back? Approximately how long? What do you think? About a week. You know, like skin is 1 day. GI is like 1 to 2 days and so forth. By 7 days, your rapidly binding cells are all back. How often do you think we give chemotherapy to patients? Tara? Once a week. That's what we call pulse therapy, folks. Where do you think that week came from? I think it's big picture first. Big picture. They're not going to ask you questions based on you got to be an oncologist. You got to know the physiology of cancer. That's what every doctor should know. Not think like an oncologist. Just know how to think through with physiology. But if I wipe out your cancer cells, you know how long it takes for the cancer cells to come back? 5 years. Hey, wait a minute. Is that why we're always talking about 5-year mortality? I think so. 5-year recurrence rate? I think so. Everybody see that? Why do you think they tell you if you get 2 normal sigmoidoscopies, don't repeat another one for 3 to 5 years? 2 normal pap smears, don't repeat another one for 3 to 5 years. 2 normal mammograms, don't repeat another one for 3 to 5 years. Where do you think these numbers are coming from? See, what you guys do, you memorize a lot of recommendations, but you don't know the origin of that recommendation. That's just like most physicians. Everybody just reads what's in an article, but they have no idea where this article is getting this information from. That's why I say you got to always go back to the basics so that you can figure out, is that article correct or not? Just like before, they used to say colonoscopy, routine colonoscopy, was to be every 7 to 10 years. Until somebody said, hey, wait a minute, what good is that? The cancer's already come. Everybody follow? That's why now colonoscopy every 5 years. That's the point. Another one, first pap smear for a female. Used to be at the year she was sexually active. Everybody remember this? The year she was sexually active, she was supposed to have her first pap smear. But Kimberly now understands you can't see cancer in the first year she had sex. Everybody see that? That's why they say now wait at least 3 years until after she's had sex to do her first pap smear. Where do you think they're getting that number from? You see, but if somebody does say, wait a minute, physiology says we got to go to these areas and push it out to 3 to 5 years, we're doing the wrong thing. But for the last 25 years, folks, it was pap smear the first time, the first year she was sexually active. That's what I mean. Everybody just follows the experts. But somebody else has got to deviate and say, wait a minute, physio doesn't say that. Where do we get this recommendation from? Well, see, it starts out with one expert, then every other expert just follows. Because he said it, he must be right. And then it doesn't match physiology, though. Okay? So you got to understand. That's why I'm always happy when I see somebody refute what we're doing out here when you can clearly see it is incorrect. Okay? But I want you to be one of those physicians who stand strong and say, no, what we're doing is incorrect. Well, anytime cancer outgrows its blood supply, it likes to go to these 6 different places, Maria. These 6 places have a lot of blood supply. So metastasis is the most common cancer in all these areas. You understand, Maria? Brain, bone, lung, liver, adrenal, pericardium. 6 places where metastasis is far more common than any primary cancer. But I can tell you right now, these 6 places have fooled the majority of you. The majority of you have picked the wrong answer when they asked you what was the most common cancer in these areas. You guys started thinking about that area rather than what the physiology says. Metastasis is the most common. So to prove that that theory is right, I already know how your brain is wired. It's already infected with the words out of the books. So I'm already going to tell you, I'm going to catch a whole bunch of you with these 6 places. I'm going to make it hard for myself, so I'm going to warn you ahead of time. Yeah. Okay, 2 warnings. 2 warnings. That's your second warning. I'm going to catch a whole bunch of you, make you victims. I can tell you right now, these 6 places have caught so many of you, you just didn't know. You were marking the wrong answer. All right, forget it. I'll give you 3 warnings. 3 warnings. That just makes it even harder now. You see? Right, Fazl? Okay, let's make it super hard. 4 warnings. I'm going to warn all of you. Watch out. Okay, 5, just so I use up the whole hand. 5 warnings that I'm going to catch a bunch of you with these 6 places. That just makes it real super hard now. Now, I know all of you are already saying, oh, no, he's not going to catch me. I'm going to get it. I'm going to get it. All right, you see. Now, you know I've been at this for a long time. I'm going to be scanning the room, scanning the room. The minute I see your mind go to sleep for a second, that's when I'll get you. Watch what happens. When you least expect it. Because I know when you're conscious of what I'm going to do, I can't get you. But the minute I see you, your mind go off track, boom, I'll ask the question. Watch what happens. The brain will spit out what it has in it. That's how I know. So be careful, folks, these 6 places. To name a tumor. Now I'm going to show you how to name a tumor. This is Dr. Francis way. It's in no book, no article. It's just a pattern I noticed. But I love it. If you want to name a tumor, the first name of the tumor, Tony, is the name of the most common cell type. Because we just said the cell goes all these transitions. Well, most common cell type, and then add oma at the end. So let's say if you ask me what's the most common skin tumor, I say, well, the skin is mostly fibrous tissue, and then I add oma at the end. I say, oh, fibroma. That way I don't have to go look it up. Okay? Anytime you talk about glandular tissue, the prefix for glandular is adeno. So then you say the most common benign tumor of every glandular tissue, therefore, catilla, you say adenoma. There it is. We just covered every gland right there. Done. Can't read that fast, folks. You cannot read that fast. But the pattern, once you see the pattern, the brain has it. It just makes sense. So, most common cell type. Now, this is where histology comes in handy. This is why they taught us histology. Now I know why. Yes, okay? So, as we go, I'll tell you the most common cell type. You just follow the rules until the brain gets reprogrammed. Everybody follow. Don't guess it for me. I'll tell you the cell type. All right, that's the name of tumor. If you want to name a cancer, Elvis, the first name is the cell type that's being irritated, because that's not necessarily the most common cell type. Let me illustrate. For esophagus, the most common cell type is smooth muscle. Smooth muscle is leiomyo. So the most common tumor, leiomyoma. Right, follow? But the most common cancer, you've got to go inside the esophagus to irritate it. The most common cell type inside, squamous cell. That's how I know squamous cell carcinoma is the most common cancer. That way I don't have to keep looking it up. All you have to do is know the histology. The cell that gets irritated is the one that's going to transform into neoplasia, not necessarily the most common cell type. All right, so the last name of a cancer is going to be carcinoma if it's epithelial in origin, sarcoma if it comes from connective tissue. You understand? You understand? Monica, you understand? All right. So let's try a couple. So that means the most common tumor of the ovary, ovarian gland. Monica. Adenoma is glandular. And the most common cancer of the ovary, Mustafa. Huh? Yeah. Watch your ending. Yeah, so say it. Adenocarcinoma. Everybody understand? I can just follow the rule. You rarely miss one. All right, Rashmi. So let's say if they ask you what's the most common bone tumor, since the bone is made of mostly osteocytes and osteoblasts, you say? Tumor. No. Go back. Look at your notes now. Don't start guessing it. If you want to name tumor, I said tumor. Cell type is osteocyte or osteoblast, so you say? Yeah, just osteoma. Don't forget the rule now. Don't start guessing it. All right? So that means if they ask you then, what's the most common cancer of the bone, since it's made of osteocytes, you would say now, osteosarcoma. And if they ask you the most common bone cancer of the right tibia, Josh, you would say? Very good. And if they ask you the most common bone cancer of the left tibia in a child who's got Paget's disease, Eros, you would say? Osteosarcoma. If they ask you, Tim, what's the most common bone cancer of the left humerus? Osteosarcoma. If they ask you what's the most common bone cancer of the right humerus in somebody who's got rickets, January. Osteosarcoma. And Melanie, they ask you the most common bone cancer of the left pelvis in a woman who's got red hair. Osteosarcoma. Tina, if they ask you what's the most common bone cancer of the spinal, the vertebral, metastasis. Bam, baby! What'd I tell you? What did I tell you? All it takes is a second. It took me all of 60 seconds to catch all of you victims already. My question, what's the most common bone cancer? You guys weren't listening. The most common brain, bone, lung, liver, adrenal, and pericardium. Yeah. Yeah. Victims in the house. Okay, baby, that took me all of 60 seconds, so I'll just give you another warning. So now it's number 6. Number 6. I'm still going to catch a bunch of you. Still going to catch a bunch of you. Oh, got to clock the first one. All right. Oh, I got to tell you a funny story. Years ago, I had made the same challenge. I gave the class like 5 or 6 warnings. So I saw one guy just getting tight and coiled, just waiting for me to ask him the question. He was ready. He said, there's no way he's going to miss this one. I could just tell he was tight. I could see it out of the corner of my eye. So I said, okay, I'm going to switch up the question. So I looked at him. I said, hey, man, what's your mama's name? Metastasis! Oh, sorry, Margie. He was just so coiled and ready. Now, I don't want you to be the opposite either. So coiled and ready, you only read the question carefully. And then you pick metastasis for everything. Okay? Remember, those 6 places only. All right? So now, trichomas. That means they end in oma, but they're not really, cancers. All right, so hamartoma, abnormal growth of normal tissue. We talked about it in pulmonary. Remember the coin lesion? Hamartoma, abnormal growth of normal lesion, of normal tissue, rather. And then choristoma, abnormal location of normal tissue. So we've talked about endometriosis, endometrial tissue in the pelvis cavity. What's the other one? Mecals, we talked about. All right, you got gastric tissue in the ileum. It shouldn't be there. All right, abnormal location of normal tissue is what a choristoma is. And they usually will ask you, which of the following is a good example of a choristoma. For hamartoma, the most common two they like to ask about, a polyp is normal mucosa, but what's it doing sticking way out there like that? And then keloid, we talked about. Granulation tissue, heaped up so big. Okay? So hamartoma and choristoma. They'll ask you for examples of each.
So keloid is hamartoma?
Is a hamartoma. Scar tissue, but it shouldn't be that big. All right, choristoma, Meckel's, and endometriosis are two best examples. So trichomas. And then we have cancers that lost their proper endings. These should actually be cancers, but they still have omas at the end. So that means if you didn't know, you swear these were tumors. Like hepatoma. Now, most books have changed it now to hepatocellular adenocarcinoma, which is what it should be. But there's a lot of old books still have hepatoma, but it's a cancer. Okay, so be careful. Seminoma is a cancer, or else we wouldn't be removing testicles for it. All right, lymphoma, that's a cancer. It should be a lymphosarcoma, connective tissue. All right, teratoma. Whenever it becomes malignant, it's still called teratoma. Okay, but it should be teratocarcinoma. Mesothelioma, when it's malignant, they don't change the name, it's still mesothelioma. But that's connective tissue, it should be a sarcoma. All right, retinoblastoma, we wouldn't be removing the eye if it was benign. All right, neuroblastoma, we wouldn't be removing it, all of them, if they were all benign. And then nephroblastoma, it says Wilms tumor, but why are we removing the kidney for a tumor? Okay, so cancers that lost their proper endings. All right, so watch out for them. And now let us begin one organ at a time, going from the top to the bottom. So this is the way we're going to do it. Brain, 4 categories. Most common intracranial. That means all comers inside this cranium. Most common one is a meningioma, the coverings of the brain. James, the 3 layers, the 3 meninges are from surface of the brain going out in order. All right, let's try Tatiana. The 3 meninges. Pia, arachnoid, and dura. Remember, PAD if you're going up this way, DAP if you're going down this way. CSF runs in which layer, Janice? Nah, Jenny. CSF runs in which layer? Nah, Ferdy. Subarachnoid layer. All right? Subarachnoid is where CSF runs. How many choroid plexi do you have, Andre? No, that means you're short. All right, Linda, how many choroid plexi do you have? 4. You got 4 ventricles. There's 1 in each ventricle. What enzyme do they use? Enzyme to make CSF. Al?
Yes, we use, well, wait a second, I can answer this in context that you've asked it, but it is called carbonic anhydrase.
It is called carbonic anhydrase. Thank you very much. All right, and then remember, it uses vitamin A as a vitamin to make CSF. All right, so if you got a meningioma, that's the meninges. That's not the brain proper. And that's why that mass will displace the brain. So on CT scan or MRI, they always tell you, this mass displaces the brain. That's how you know it's not part of the brain proper. Meningioma. And then because it displaces the brain, it crushes those cells underneath it, forming a lot of calcifications, which we call psammoma bodies. Well, Linda, the calcifications that we speak of, are they dystrophic or metastatic? Dystrophic, remember, a cell has died, it calcified. So here, you see one big old rock, and that's why they renamed it psammoma bodies. All right? When do you see metastatic calcifications? Nicole? So when you have hypercalcemia for any reason. All right? So not just from any other place. It has to be hypercalcemia. All right, so we can use Dr. Psammoma's name to name the 4 neoplasms that have psammoma bodies, Cammie. P for papillary carcinoma of the thyroid. S and the A go together. So serous adenocarcinoma of the ovary, meningioma, and mesothelioma. That's because these 4 neoplasms crush so many cells nearby, you see a big old rock, not just microcalcifications like in other cancers. Okay? So the 4 neoplasms associated with pneumoma bodies, know them, very high yield. Yes, Tony.
Is the most common administration upon all issues?
Yeah. Mm-hmm. All right, the next category, most common primary brain tumor. That means, Tina, of brain substance proper. That, remember, meninges is not brain substance. So primary, if they use the word primary, then you say, well, what's the most common cell type? Astrocyte. And therefore, Tina says, the most common tumor is astrocytoma. Remember, just put oma at the end. Or they'll get specific and name the 3 types of astrocytes. Glial cells, so they'll say glioma. Oligodendrocytes, remember, myelinate your nerves, so oligodendroglioma. And then ependymal cells line the CSF canals, so ependymoma. Okay? So how do I separate these 3 out? No problem. Gliomas, majority of them are seen in optic nerve glioma. You'll see monocular blindness. What, January? If I'm blind in the right eye and I shine a light in my right eye, what's going to happen to my left eye? Huh? You got a tumor in your right eye, you can still sense light? That's the trick to the question. You see that? They ask you what happens to the other eye, like something's supposed to happen. If you got optic nerve tumor, you're blind in that eye. It's like retinoblastoma, you go blind, that's it. Shine a light, nothing happens in this eye or that eye. Remember, you got to sense it to respond. So they talk about ipsilateral or consensual. Okay, so that's how you know they're blind in one eye. Optic nerve glioma. Okay? Second one, oligodendroglioma. They wrap around central nerves, so we can look at that. If it's peripheral, then we call them schwannoma. Well, look at this. They talk about, you see that? See that? Layers of myelin. But they use the word whirling pattern. I just like to look at the picture and say, oh, that's just myelination and layer after layer. Oligodendroglioma. If it's the CNS, schwannoma if it's the PNS. You may even see a few microcalcifications, but every tumor could do that, so that's not really that much of a clue for me. Okay? Ependymoma are seen in ependymal cells. 90% of ependymomas occur in the sacral area. And because it occurs in the sacral area, Manny, we usually have no symptoms from it. Why? Your spinal cord ends at L1, L2. Why do I need to know that? For the boys 2 and 3 people, they're going to ask you, where do you do a lumbar puncture? That's how you know. Go to L3 or L4. You know, the hips. So all we do is feel the iliac crest, go right there or one below. L3, L4. Okay? Spinal cord ends at L1, L2. So that's why if you have it in the sacral area, it's below the spinal cord itself. Doesn't compress anything, no problem. Everybody follow that? Okay. Now, the ones they write about in the book, see that? The 10% shows up in your books, are the ones in the brain that cause hydrocephalus. Why? Because we were shocked when we saw this stuff. But the 90% is what they're going to be asking you about on the exam. Okay? Everybody follow? Now, let's look at the spinal cord. Spinal cord ends at L1, L2. The rest of the nerves come out to the side like this, looking like a horse's tail. So they call it cauda equina, horse's tail. The tip of the spinal cord at L1, L2 looks like a cone, so they say conus medullaris. Everybody understand so far? And then there's a little tissue that goes from the tip of the cone and anchors it to the bottom of the spinal canal called the phylum terminalis. Everybody follow me? All right, now, there's 3 syndromes down there they want you to know about. 3 syndromes. You got to know how to differentiate, Monica. Number 1 is called spinal stenosis. Cause, usually arthritis. So you got osteophytes and everything sticking into the spinal canal, compressing the spinal cord. Spinal stenosis. How do you know you have it? When you're using your back a lot, all of a sudden it'll hurt. When you use your back a lot, when you're walking up and down hill or stairs. It hurts real bad because now you're compressing it a lot. So how do you relieve it? You sit down and then lean forward. You see that? Everybody understand? When you lean forward, you're separating like that. You're stretching the lumbar area, and so that means the spur comes off the spinal cord, and that's why they feel better. So for that one, they'll describe it and ask you the diagnosis, usually on boards 1. On boards 2, they'll usually ask the most common cause of it. That's usually osteoarthritis. Okay? For all of these, MRI will diagnose it for you. All right, the next one, Cauda-Equina syndrome. Cauda-Equina syndrome, remember I just said, at L1, L2 is where you end. Then everything else, all these nerves are going to come off laterally. So Cauda-Equina syndrome will start involving nerves from L1 all the way down to S5. All right, now watch carefully. L1, L2 is the hip. L3, L4 is your knee. L5 is your big toe. S1 is the Achilles. And then the leg, S2, thigh, S3, and the rhino-rhino-anal area, S4, S5. So that means it's going to go from one leg, go around to the other one. They call it saddle anesthesia. Like if you were in a saddle of a horse, all that area will be numb and weak because it involves from L1 all the way down to S5. Saddle anesthesia is a classic clue for Cauda-Equina syndrome. Again, osteoarthritis usually what's doing it. Something's compressing that whole area. Okay? And then finally, conus medullaris syndrome, Tatiana. The conus medullaris is primarily S4, S5. Where is that going to be found, Tatiana? Where are you going to be numb? Well, where is that in your body? S4, S5, Janice. Your butt. Oh my gosh, just saying the word anus now scares the heck out of some of you. Perianal anesthesia. The guy will tell you every time I wipe my butt, Doc, I can't feel a thing. Classic conus medullaris syndrome. It's just around the anus. S4 and S5 are right around the anus, folks, not the butt. S4 is right around the anus. Okay, so perianal anesthesia. Does everybody now understand how to separate these three syndromes? They're easy to separate if you understand the nerve roots involved. Okay? But a patient will come in with these problems, especially elderly patients. You got to know how to separate the three of them out. Yes? What's that? S2 would be the leg, lower leg. S3 would be the thigh coming back up. And then perianal, S4 and S5. Yep. All right, so that's ependymomas. Now, neurocutaneous syndromes have a high incidence of gliomas and astrocytomas, so we need to talk about them. Dahlia, your question first. Yes. It could be at any level. It could be at any level, yeah. Most of the time it's down in lumbar area. You wear that out pretty early. Yeah. Remember that lumbar osteoarthritis is the most common location for osteoarthritis. Now, why do I tell you that? Because if you read your Robbins and your Harrison, folks, they talk about the knee and the hip. You guys swear that's the answer when they ask you, what's the most common bone involved in osteoarthritis? You quote what the books say without thinking about it. Osteoarthritis just has to do wear and tear. All you do is ask yourself, what joint do you wear out first? You got pressure on your lumbar area the day you were born. You were floating in water for 9 months, but as soon as you come out, even a baby that can't walk is still putting pressure on the lumbar area. That's how to remember. The problem is they're usually not symptomatic, and that's why people don't come and complain about it. And so then when they ask you the question, you pick hip and knee, because the books keep mentioning hip and knee. That's because those become symptomatic early and they come in complaining. But most common is just based on physiology. Okay? All right, neurocutaneous syndromes. We call them neurocutaneous because they all have neurological problems and they have cutaneous problems. The neurological problem is the same for all. Cutaneous is different for each. They all have mental retardation, seizures, and cerebral calcifications. That's the neurological component. Now, that's not to say every single case has all three problems, but that's the constellation of symptoms. They all have tumors associated with them. Some have cancers. That's what's different. That's why they want you to know this. But they all have different cutaneous findings. Mental retardation. Bartholin, what's the average IQ in America? It's a range. 85 to what? No, the IQ is 85 to 100, Bartholin. It's a range. It's not just one number. 85 to 100. Standard deviation, Katia. 15. How many standard deviations above normal push you above the 95th percentile? 2. Remember, 168, 295, 3.5, 99. All right? So, what IQ pushing the superior range? Rashmi? Above 130. If your IQ is under 25, what do I do with you? Nicole? Institutionalize or have 24-hour care. If the mom stays at home all day, no problem. Okay? All right, seizures. Let's talk about seizures. Let me teach you all about seizures. All right? This is the application of all the stuff that you learned. I'm going to show you how to apply it. What is the definition of a seizure, first of all? The definition of a seizure, spontaneous, uncontrolled, two key words, spontaneous, uncontrolled depolarization of the brain. Then we call it a seizure. I'm not going to get a clean piece of paper because we're going to go through all the seizures. I'm going to show you how to differentiate every one of them. All right? Spontaneous, uncontrolled depolarization of the brain. Then we call it a seizure disorder. Okay? If it's recurrent and idiopathic. See, now we've added two more words. Recurrent and idiopathic, which means you've done a lot of workup, can't find a reason, and then you get it again, then we call it epilepsy. So you got to know the difference between seizure disorder and epilepsy. If you know why they're having seizures, you can't call it epilepsy. Epilepsy is reserved for people where we don't know what's causing their seizures. You better understand how to differentiate seizure disorder from epilepsy. Epilepsy means it's recurrent and it's idiopathic. We have no idea why they're having it. Seizure disorder says we know why they're having it. Everybody understand me? So more like depolarized. That's it. You got to figure out why they're depolarizing. All right, next thing. Generalized versus focal. The only way to differentiate generalized seizure, loss of consciousness. Which means you depend on other people to tell you what happened. The person was not there at the time. They were not conscious at the time. The person who has to ask people around him what happened, that was a generalized seizure. The person who's still talking to you or talking to people around him while he's having a seizure, that's a partial seizure. That's a focal seizure. A lot of students tend to describe it based on what parts of the body are shaking. And I say, no, that's not it. And that's why they entice you with that on the boards. Tell you his whole body's shaking. But they also tell you he's talking to his brother or sister at the same time. Well, that's still a focal seizure. Everybody understand? Partial versus generalized seizure. All right, physiologically, what does that mean? Again, I always want you to visualize physiology. Partial seizure, focal seizure means only part of the brain is depolarizing. That's why they can use the other part to think and talk and whatever. Partial or focal seizure means only part of the brain is depolarizing, so the other part is still working and you can think and talk with it. Whereas pernema, in a generalized seizure, the whole brain is depolarizing. And so you have no sodium channels to use to think or recover memory or to talk, and that's why they can't do it. Everybody understand the difference? By definition, by description, and by physiologically what's going on. I want you to know the difference. Okay? Generalized versus partial. Now, anytime you're having a seizure, that sounds like a medical emergency to me. Josh, anytime you have a medical emergency, what's the first thing you want to do? Airway, breathing, circulation. Folks, that doesn't change. Again, just showing you. Apply what you already know. Don't start thinking about something new just because, oh, it's now managing seizures. And then you start thinking about something else. All right? It's still airway, breathing, circulation first. Okay? Everybody understand? But here's the deal. They say do not put anything in their mouth. Because they tend to bite down on it and they aspirate the popsicle stick. Now they perforate the esophagus. Now you got a surgical emergency on top of seizure. Okay, so we don't do that. So what do? We turn their head to the left. Why? In case they vomit, we want esophagus slightly on the left. We want to just come rolling out. We turn their head to the left. We put pillows around them. Why? Because they're bouncing up and down. Head injury is the #1 cause of death during a seizure. So you put a pillow around their head. That way their head hits the pillow and not the ground. Okay? Now, more application, Kimberly. If you're having a seizure, that's pretty stressful, is it not? What's the first discharge out of the brain whenever you're stressed out? Sympathetic or parasympathetic? Parasympathetic. That's why they foam at their mouth, bite their tongue, defecate, urinate. All that is parasympathetic, folks. That's all it is. Which means they could run off a bunch of other parasympathetic bradycardia. Even though your book never mentioned it, it follows parasympathetic. I say, yeah, why not? Everybody understand me? Okay, stress response is all you're seeing. Now, anytime you got seizure, that irritates the brain. Inflammation starts. If inflammation starts, Thomas, what's the first visible change of inflammation? Swelling. If your brain swells, what happens to intracranial pressure, Thomas? Increases. Anytime intracranial pressure rises, 2 hormones can be released. Number 1, you compress those dopamine fibers coming down from hypothalamus, prolactin. So high prolactin is seen after a seizure. You can measure it. And then SIADH occurs after a seizure because ADH can also be secreted because of intracranial pressure. Remember we talked about 5 reasons for ADH. Intracranial pressure was one of them. So high prolactin, high ADH are the 2 hormonal problems you see right after a seizure. Now, after a seizure, folks, you got to reset the concentration gradients. Sodium back out, potassium back in. How am I going to do that, Melanie? If you got to reestablish your concentration gradients. Who reestablishes your concentration gradients across the membrane? No. January. Sodium, potassium, pump. And that means you're going to burn up a lot of ATP. You understand, Dan? And if you burn up all the ATP in your brain in an instant like that, that's why they're post-ictal. That's why they're real drowsy when they come out of it. See that? They're real slow mentation. And then they kind of slowly come out, hey, what happened? See that? Now all the sodium channels are available to them. They can start firing again. Okay? In fact, the low ATP can be so severe, they can be paralyzed right after a seizure. We call that Todd's paralysis. Todd's paralysis, seen after a seizure, is from total lack of ATP. Okay? What? Todd, T-O-D-D. Yeah. All right, so now that's our seizures. Now, if somebody is diagnosed with epilepsy, you have to notify the DMV. Because remember, they pass out whenever they're having a seizure. If they pass out behind the wheel and you haven't told the DMV, you're liable. So this is how their whole life will change. That's why it's important that you know the difference between seizure disorder, which means know the cause, they can still keep driving, versus epilepsy, we don't know the cause. No, we have to notify the DMV. The DMV will take away their license until they are seizure-free for at least 6 months. That means their whole life is about to change, especially, let's say, if they're a truck driver, cab driver, bus driver, your job just ended. Okay, but better that than them, for them to kill everybody in that bus while driving. Okay? You must treat them with medication, minimum 2 years. Minimum. Most of them stay on medication for life because we can't figure out, we can't wean it off. Every time you try to wean it off, it starts up again. Okay? Everybody understand management. Now, the different types of seizures. Okay? Generalized seizures. The most common type, tonic-clonic. How do I know it? Tonic means the tone of your body changes. They arch, they stiffen. Clonic means your body starts jerking. That's exactly what people describe. He stiffened up and then he started jerking. As I know, tonic-clonic. Now, that's not to say that every tonic-clonic is going to be generalized, because some of them are doing that and they're still talking to you. But that's the most common generalized seizure. All right? Then there's febrile seizure. Very common in children. Has 6 major criteria. Febrile, look at the word. Febrile. Criteria number 1, you got to have a fever. That means they don't have a fever in the vignette. Don't say it's a febrile seizure. Don't even bring it up. Criteria number 1 says you got to have a fever at the time. It has to do with how fast the fever went up and irritate the brain. It could be any level of fever. So don't say, oh, it's only when it's above 102. Any fever. I've seen it at every level. Okay? It just has to do with how fast it went up, irritate the brain, and start firing. So criteria number 1 has to be with a fever. Number 2 has to be generalized. Number 3 lasts less than 20 minutes in over 90% of cases. It's rare going to last longer than that. If it lasts longer than 20 minutes or recurs, then we say complex febrile seizures because the fever is still there. So fever, generalized, less than 20 minutes, normal neurological exam before and after because there's no neuro disease associated with it. Normal neuro exam before and after the seizure. Number 5, normal EEG because it is not epilepsy, so you're not going to detect anything on EEG. And the age range, 6 months to 6 years of age. They outgrow it. And the good thing about this one, May, you just treat the fever, and it goes away. Not a big deal. Okay? So tonic-clonic febrile. 6 months to 6 years of age is the age range. Normal neurological exam before and after. All right? Then there's temporal lobe seizures, or sometimes they call them psychomotor seizures. Temporal lobe seizures means it originates from the temporal lobe where hallucinations are supposed to be stored away. So classic clue is they have hallucinations right before the seizure. Temporal lobe seizures. I had one family who had a genetic type because the mom had it and both of her daughters had it. The daughter would always see small, real tiny spiders on the wall right before she had her seizure. That's how she knew it was about to happen. And then I think the other sister saw big things, and things look bigger. So they call that macropsia. Things just look larger than they are. The other little girl had micropsia. Everything looked smaller than it was supposed to be. For her, it was spiders. Okay? So temporal lobe seizures. Right before the seizure, yes. Right, exactly. Then there's benign, because they are, Rolandic seizures, the guy who discovered it. Benign Rolandic seizures. Classic history, which means they outgrow this one. But this is what you hear. Mom is awakened at night because why? The kid sprung up in bed, made a loud noise when he sprung up real quickly. And then if she happens to rush in the room, this is all she'll see. His eyes will just flutter. And then fall back to sleep like nothing happened. And if you ask him in the morning, did you remember what happened? Yeah, what? What? I mean, you could even wake him up at that point in time. What happened? No, what? He's trying to figure out why is mom waking him up. It's benign. So you don't have to treat those. But you got to explain to mom, it happens. No big deal. Benign Rolandic seizures. No. Night terrors, they scream and shout. Yeah. All right, then there's myotonic seizures. Myotonic, the word means increased muscle tone. Myotonic seizures. Okay, also known as salam seizures. It usually involves the abdominal muscles contract suddenly. And when it contracts suddenly, your arms come flinging forward as if you were saying salam. But that's why the mom will hear, ha! But the arms come forward. Salam. So it got the nickname salam seizures. But when it's like somebody taking the wind out of you because it makes your abdominal muscle contract real suddenly. Myotonic, increased muscle tone. Okay? Now don't get it confused with, what's the one that occurs in babies? Remember the name of the one that occurs in babies early in the morning too? It's like myotonic seizures. No, it just came in my mind and went away. Occurs in babies. Myotonic. Came and went again.
Just pick the first thing that popped into
it just came and went again. Doggone it. Infantile spasms. Thank you. Yeah, thank you. Yeah. I just want to make sure everybody understands this is different. Infantile spasms occur primarily in infants. Look at the name. Infants. First, from 1 month to 12 months. That's the first clue. Myotonic can occur at any age. Okay? And the child just has a spasm. But that one can be treated by giving them ACTH injections. Yeah, the infantile spasms can be treated. Myotonic is going to be treated totally differently. So again, infantile spasm is similar to myotonic seizures, but occurs only in the first year of life. That's the key, is that clue. Okay? All right, the other one's atonic seizure. Atonic seizure. Atonic means without tone. Where does tone come from? Corticospinal tract, frontal lobe. That's how you know the seizure started in the frontal lobe. They lose all body tone and drop to the ground like a wet noodle. Atonic seizure. A lot of people think is the cataplexy you see in narcolepsy, when they just drop. Except this one, they'll drop and then they'll start writhing around like a snake. And of course, they have the postictal period. You don't see that in narcolepsy. Okay? It's an atonic. Then there's, let me see, when there's too many of them. Oh, Lennox-Gastaut. Lennox-Gastaut syndrome is when you got hundreds of seizures being fired off every day. Okay? No, yeah, any seizure, but they're firing off, hundreds. 200, 300, 400 at a time, I'm telling you. And then there's mixed. Okay? And then we call it status epilepticus whenever the seizure is more than 20 minutes consecutive. Remember, what organ are you afraid is dying right now if you have a seizure more than 20 minutes? Diana. The brain will be the first one to go. That's why you need to do something right away. All right, so here's how you treat them. In general, generalized seizures in children, phenobarbital. Almost all these drugs we've talked about. How does phenobarbital work? Or the lead? Kimberly, how do barbiturates work? Michelle? Increased duration of chloride channel opening. Remember, benzos increase the frequency. All right, so generalized seizures in children, phenobarbital, generalized seizures in adults, phenytoin. How does phenytoin work, January? Yeah, blocks sodium. And then also blocks calcium, but it's the sodium that's stopping the seizure. All right, febrile seizure, acetaminophen. Chukuma, what's the main acetaminophen toxicity you have to worry about? What? Hepatotoxic. Micro or macro steatosis, Tony? Micro. Two other diseases that give you micro besides acetaminophen? You see pregnancy and Rye syndrome. Diana, treatment for acetaminophen toxicity. All right, Ferdy. Oh, wait a minute. Did you say something? You got it? No, there's a drug you have to use. Ferdy. N-acetylcysteine. Remember, the drug destroys sulfur groups in the liver, so put the sulfur back. Okay, and which hours level makes that decision for you, Al? 4 hour. If it's high, you must treat them. All right, so that's, which one was I doing? Oh, febrile seizures. Temporal lobe seizures, carbamazepine. Give me one side effect of carbamazepine, Fazil. Agranulocytosis and SIDH. You the man, Fazil. Good job. Benign Rolandic seizures, like I said, they outgrow. No big deal there. Myotonic valproic acid. So myotonic or mixed, we treat them with valproic acid. How does that drug work, Andre? If you want to block a depolarization, Andre, what ion do you want to block? Yeah, remember, use the physio to figure it out, or else the mind just starts guessing things. It's got to follow the physiology. So valproic acid blocks sodium and then calcium. So myotonic or mixed seizures, valproic acid. But remember, you got to worry about bone marrow suppression, hepatitis, and then neural tube defects in babies. Infantile spasms, remember ACTH injection. Atonic seizure is just another generalized seizure. Lennox-Gastaut, you do a lobectomy. We do an EEG and track where all the seizures are coming from, and whichever hemisphere has the most seizures, we cut that hemisphere out. Yeah, it's drastic, but if you don't, they're going to die anyway. Okay? And then status epilepticus, remember, diazepam, first line, lorazepam, second line. Lobectomy. Yeah. Dahlia? Yeah. Right. Right. It means they're firing out hundreds of seizures uncontrolled by medication. Yeah. Yep. That's correct. It could be at any age. It could be at any age. No. It can happen in anyone. All right, so the question was just what Lennox-Gastaut was. You can start out with any seizure disorder, and then when you fire off enough seizures, then we say you got Lennox-Gastaut syndrome. Okay? Now, workup of a seizure patient. Number one cause of a seizure is what, Joseph? Let's see if Frankie remembers. Number one cause of a seizure. But number one cause of it. Nita. What's that? No, Jennifer. It's called ischemia. Oh, they forgot already. Okay, I told you folks, you forget your concept, you swear we never talked about it. We've talked about all of these. All I'm doing is just show you how to organize it now. But don't forget your concepts, or else you're going to be stuck in the details of that vignette now. And then all of a sudden you swear you don't know the most common cause of this seizure. Instead of just saying what causes all seizures, the same answer. That's why oxygen is first. I mean, stop the hypoxic part first. All right, so after that, rule out mass lesion. How do I rule out a mass lesion? Joseph. A CT scan or MRI. You can speak up, man. Stop whispering back there. So CT scan MRI would be the next test. So you put oxygen in their face, CT scan MRI. It's the first test you're going to run. The next most common cause of a seizure is an infection. Irritating that area. Chikuma, how do you rule out infection? Huh? Nah, there's a better way. Ajay. Tamir. How do I know you got an infection in your brain, Monica? Yeah, you guys got lost of where we were at. All right, Monica, what do we do? What? Mustafa. It's called lumbar puncture. If you want to know specifically the brain's infected, do a lumbar puncture. Folks, don't forget, your answer must match where they're talking about. Okay? I'm still hearing too many of those mistakes being made. All right, so that's how you work them up. And then after that, it's more like depolarized problems, so electrolyte problem. That's why you always put oxygen on them, do a CT scan, MRI, lumbar puncture, then you check the electrolytes and chem profile. You're looking for all the things that make you more likely depolarized. That's it. That's how you work them up. That means everything else after that is rare. That means before you pick all these rare syndromes. And that's the reason why I stop and talk about it here, because these syndromes are rare compared to what I just told you. Because I know the syndromes are what's in your book, but that is not the most common if they ask you. Everybody understand? All right, cool. Now we go back. Oh, that's right. I forgot about that one. Thank you. Absence seizures. Absence seizures are the most common seizures in children. Class includes the staring spells. Staring spells. So the teacher will say he always seems to stare into space. Or his friends will say, oh, man, he's always just looking like he's not even there, Ms. Johnson. You know? Absence. Staring is the only seizure without a postictal. They're not drowsy afterwards. They just snap in and out, just in and out. Absence. If you want to bring it out in your office, make them hyperventilate. And it'll start right there in your office. Cammie. Absence is a generalized seizure, correct. Okay? Yes. No, 1 to 12 months. Infant is 1 to 12 months. All right, absence, the treatment, remember ethosuximide. Ethosuximide is first line, and then clonazepam was the benzo we talked about. That's the second line. Dahlia, question. Right. we call it a seizure disorder. It's not called epilepsy. If you know why they have hypoxia, like if they get a viral illness and get a seizure, you don't call it epilepsy. It's due to the viral illness. Yeah. All right. Yes. No. That's the next part. Now, what is it called? The focal seizures can start anywhere in the brain, and you can tell by what part of the body is shaking where it's occurring. Remember, legs, the midline, arms, the lateral, that kind of thing. Okay? And any time a focal seizure involves the entire body, it marches up the body, we call it a Jacksonian seizure. Old name was marching. It would start with your finger, and then just march up the whole body. It looks like it's generalized, but it really isn't. Okay? But it's still a focal seizure. For those, obviously, you treat it and you work them up. You got to go rule out what mass or something is irritating that part of the brain. So that one is usually going to be seen on a CT scan or LP, because either it's a mass, blood, stroke, whatever, or an infection irritating it. So that's Jacksonian. Jacksonian is when a partial looks like it's generalized. Oh, the other thing on absence, on the EEG, you got a characteristic. They call it a 3 per second spike and wave. That means 3 spikes in a wave form. Every second, you see 3 spikes. 3 per second spike and wave pattern is a classic EEG finding. Okay, now we can differentiate the syndromes. Neurofibromatosis, on their skin you see cafe au lait spots, which they'll describe as hyperpigmented macules. They'll usually describe it. For the boys 2 and 3 people, you need at least 3 of them, at least 1.5 centimeters in diameter to make this diagnosis. Because a lot of people have small ones when they're born. That's no big deal. You need at least 3 large ones, at least 3 which are at least 1.5 centimeters in diameter to make the diagnosis. Neurofibromatosis is associated with chromosome 17 and 22. Type 1 is with chromosome 17, since it has a 1 in it. Type 2 is with chromosome 22, since it has 2s in it. That's how I keep them straight. Because type 1 is peripheral tumors. Type 2, central tumors. Since right now we're central, it's type 2s that we're talking about most of the time. But you can tell what tumors they have is right in the name, neuromas and fibromas. Neuromas and fibromas. But what about diseases associated in general with cafe au lait spots? Anytime you see cafe au lait spots being itched, there are 2 diseases you need to rule out. Number 1 is neurofibromatosis that we just talked about. Number 2 is called McCune-Albright syndrome, which is cafe au lait spots associated with bone tumors and precocious puberty. So McCune-Albright syndrome, cafe au lait spots associated with precocious puberty and fibrous bone tumors. Usually on boards 1, they tend to ask you, what is it? That means you got to be able to put all the things together. On boards 2, or sometimes they'll give you parts of it and then ask you what else you need to look for. What else do you need to rule out in this patient? That means you got to know the whole syndrome to know what else to rule out. So cafe au lait spots, 2 syndromes. All right, the next one, Sturge-Weber syndrome. On their skin, what do you see? A large red macule called a port wine stain, usually on the forehead. A large red macule called a port wine stain, usually on the forehead. Since this is a blood vessel right here, that's how to remember. They also have other angiomas, blood vessel tumor, angiomas of the retina and brain. Sturge-Weber syndrome. Port wine stain, usually an ophthalmic division of CN5, along with angiomas of the brain and retina. And then the worst one, tuberous sclerosis, which I don't think is one of your slides. Just write this in. It for some reason didn't print off. Tuberous sclerosis is the worst one. Because on the skin, you see ashen leaf spots, now described as hypopigmented. So remember, cafe au lait, coffee, dark. So they'll say hyperpigmented macules. This one's light colored, hypopigmented macules. And then right there in its name, tumors. They have primary brain tumors, which we call tumors. They have rhabdomyomas and sarcomas of the heart. It's never good to have tumors and cancers wrapped around your heart. And then renal cell carcinoma. That's not good either. Eros. which, oh, that's bone. Sorry. Thank you. That should have printed off his brain. Thank you very much. Yes, primary brain tumors. There was one other syndrome we've talked about. Bartholin has a high incidence of renal cell carcinoma. What was that syndrome? Another syndrome with a high incidence of renal cell carcinoma. What was it? Let's see if Tara remembers. Von Hippel-Lindau. So now you got two syndromes with high incidence of renal cell cancer. Von Hippel-Lindau, remember, had AVMs in the abdomen and brain. Now you got tuberous sclerosis. So anytime you see renal cancer, folks, there's two syndromes you better make sure that patient doesn't have, because they're going to come back with other things later. Yes?
Just to clarify, did you say tuberous sclerosis was the worst?
It's the worst because it has the worst cancers associated with it. So you got brain tumors that can kill you. Tumor around your heart can kill you. Renal cell carcinoma can kill you. All right. Now, most common primary brain cancer is just a high-grade astrocytoma or glioblastoma multiforme. Glioblastoma multiforme, that's just a carcinoma. And then, of course, the most common cancer, metastasis, if they say it that way. The most common cancer. Well, the brain has a lot of blood supply, so a lot of cancers come there looking for blood. The classic clue, you'll see the metastasis is usually at the gray-white matter junction. So they say that's where blood comes into the brain. So if they say you see masses at the gray-white matter junction, classic. You got metastasis. Okay, so those are categories for brain tumors and cancers. Pituitary is a gland. So the most common tumor, the pituitary, eros, adenoma. Anything glandular, adenoma. We've talked about this before. 95% of cells in pituitary are non-functional. So it would be a non-functional or chromophobic adenoma. They don't want to be specific in naming it. Only 5% produce hormones. Some of them are basophilic. Some of them are acidophilic. Well, the acidophils only produce two hormones, growth hormone and prolactin. Those are the ones they love. Okay, because then there's only two answers you can pick. Acidophilic adenoma can only be growth hormone or prolactin. Remember, they're related. And then basophilic produces four hormones. They usually don't ask about those. But if they ask the most common functional tumor, because the most common tumor is based on the most common, and that's non-functional, 95% of the time. Most common functional, that's only 5%, is a prolactinoma. But as I showed you, Fazil, that anytime you have a pituitary tumor, you're going to see you're cutting off the dopamine fibers from the hypothalamus. What hormone is going to be elevated? Prolactin is high with every pituitary tumor. That's not to say the tumor is producing it. That's the trick to the question. So they love to ask, well, gee, what's the most common pituitary tumor, Frank? You say functional or non-functional? Non-functional, that's 95%. And then functional, you say prolactinoma. But every pituitary tumor has high prolactin associated with it. So what do you see? Galactorrhea, remember that? And amenorrhea. Why do we see amenorrhea? Because high prolactin, remember, blocks GnRH as well as TRH. So you're going to see hypothyroidism eventually too. Okay? How do we, so that's a classic presentation of pituitary tumor. Another classic clue for pituitary tumor, it's right underneath the optic chiasm. Remember the nasal fibers crossed there. Bitemporal hemianopsia. They can't see the sides. So when they're driving, they have a hard time seeing the cars on the sides. They classically tell you that. Bitemporal hemianopsia. Most common cancer is adenocarcinoma. Rare. Nobody talks about it. Neither shall we. Next one. Pineal. Pineal gland is responsible for doing what, Elvis? Circadian rhythms. Tells time. Pineal gland tells time. Most common tumor, Rashmi. Pinealoma or pineal adenoma, either one. All right? The pineal gland is just lateral to the pituitary, and cranial 6 runs right lateral to that. So it pushes on CN6, and your eye then turns in. Remember, 6 does lateral rectus. Okay? Or you get precocious puberty. Puberty is precocious when it occurs before age 9 for a male, 8 for a female. So 2 years below what we're seeing. That means 10 for females, 11 for males right now. Okay? Then we say precocious puberty. Everybody understand definition first? All right, so here comes a little girl, age 6, and she's got all these changes. You're like, ooh, precocious puberty. Question is this real, which means controlled by the pituitary, or driven by hormones produced by some tumor? Everybody follow me? That's the first question you got to ask. Is this real, or is it driven by some hormone coming out of a tumor? The way to prove that it's real, if it's coming from the hypothalamus, is if I could block the GnRH that came from the hypothalamus. You understand, Ajay? You understand, Chikuma? Do you know of a drug that can block the GnRH coming out of your hypothalamus? Ajay? Bartholan? All right, it's called Leuprolide. Leuprolide, you learned it in reproductive endocrine. We give them GnRH. This is so the board student 3 people know how to work this out. You give them GnRH, I should see a drop in their estrogen if it's a female or testosterone if it's a male the next day. If it's a drop the next day, then it's real. Does everybody understand that? Because if it's come from a tumor, the tumor doesn't respond to GnRH. Everybody follow that? Does that make sense to everybody? Anybody who comes in precocious puberty, you got to define, is it real or is it being driven by a tumor? You give them GnRH right away, Leuprolide. If their estrogen testosterone drops the next day, which one is that, Melanie? Is it real or driven by a tumor? You give them GnRH and their estrogen or testosterone drops the next day, Melanie. Which one is it? Only the hypothalamus responds to GnRH. So that means you can only block the one coming from the real. That's the hypothalamus. So the next day you'll know if it's real. Then we keep them on Leuprolide until they're right age to go through puberty. Everybody follow that? Because if you let them go through puberty at age 6, that's no good. You got a little girl who has no idea what menses is. All right, so you keep on Leuprolide until about age 12 or 13, and then let them start bleeding. Okay? The youngest I ever seen in my office was age 6, going through puberty already. And she was living with Grandma. I said, oh, Grandma, we got problems. Surprise, surprise, you got something coming. The youngest I've ever seen have a baby, age 8. So they're quite sexually active. Now you got to ask yourself, who was she sexually active with? 8-year-old girls can't get pregnant by 8-year-old boys. When you see a young girl get pregnant, folks, now I used to get so mad at this. Everybody wants to start calling a little girl a slut. And I'm saying, wait a minute, what about the man who slept with this little girl? How come nobody's calling him anything? You know, they're going to bed with men who are 18, 19, 20. Simply because the little girl's got the body of a woman, but remember, she's at the age where she just likes attention from boys. And that's all it is to her. She has no concept of the consequence of getting pregnant. She's not even sure what sex is. All she knows is a guy tells her to take off her clothes and it's attention to her, so she does. And then before you know it, she's pregnant. All right, so the key is to find out who the heck impregnated this little girl. And don't take it out on a little girl. She's just being a little girl. All right, so that's pioneering and precocious puberty. So now if the estrogen testosterone does not suppress the next day, then Melanie, you know it's driven by a tumor. And then, of course, we're going to talk about various tumors who have it. And so pinealoma is just one of the ones you got to rule out. Okay? You understand, January? You understand, Melanie? It's okay. You understand, Tina? All right. All right, posterior fossa tumors. How do I know you got a tumor in your posterior fossa? You're going to vomit first thing in the morning. Why? Think about this, folks. If you're lying down, let's say your head is over here. If you're lying down and that tumor is sitting right here at the bottom of your head, in the back, right? It's laying on the back of your head. So it's laying on a pillow. No problem. As soon as you stand up in the morning, then that tumor, boom, falls to the bottom, the base of your brain. The base of your brain is where the floor of the fourth ventricle is. Isn't that one of your vomiting centers? Chemotactic trigger zone. They vomit the minute they stand up every morning. Everybody understand? You understand, Mustafa? You understand, Tina? Understand, Miguel? All right, so early morning vomiting is a classic sign of posterior fossa tumors. All right, these are most common in children. The most common, medulloblastoma. Yes, sir. That's a cyst, though. Tumor. Yeah. Medulloblastoma is cerebellar origin. Cerebellar astrocytoma. The problem is it sits on top of the medulla, so they thought it was a medullary origin, but they never went back to rename it when they found out where it really came from. Okay, so of course now they use it against you on the boards. All right, so medulloblastoma, or they'll just say, cerebellastrocytoma. The problem is the tumor is falling on the fourth ventricle chemotypic trigger zone. Craniopharyngioma developed from Rackey's pouch. Rackey's pouch, remember, it's supposed to give rise to the posterior pituitary, develops in the roof of your mouth. Oh, sorry, adeno, the anterior pituitary. Posterior is neuro. So Rackey's pouch develops from the roof of the hard palate. It's supposed to give rise to the anterior pituitary. So they can have all these anterior pituitary hormonal problems. There's so many of them. The classic clue, however, is when they cut into it, it looks like motor oil. It just has a very oily appearance. Now, I don't know if it's 10W30 or 10W40. I don't stick around long enough to find out. I click, and I move. The minute they say greasy, oily, click, click, done. Last time I did it with a student on Usmle World, they just mentioned it had a cholesterol appearance. I was like, man, sounds like oil to me. Click, you keep on moving. I'm telling you, don't read past a classic clue, folks. You don't get any better than that. Anything else, and weak clue. The best ones, I click and I move. I don't want to read anything else. All right, so craniopharyngioma and medulloblastoma. Now, why today? I used to hear on soap operas all the time, he has inoperable brain tumor. And I'm saying, wait a minute, a tumor should be operable. Well, here's the reason why, inoperable brain tumor. Because the tumor is sitting right on your medulla. If my knife hits your medulla, you die right there on the table. Everybody understand that? Can't cut the medulla. That's why so many of these tumors, even though they're benign, are inoperable. So what do? Cut out as much of it as we can and then radiate the rest. What is radiation supposed to do for you, Pranima? I'm hoping to induce a new mutation that'll stop the first mutation from growing. Everybody understand? But sometimes a new mutation that you induce will make it grow some more. That's why radiation